Hello everyone, this is Dr. Vishal Gabale, and you have two sessions already seen in symptomatology till now. First was dyspnea, second was cough. This time I wanted to be a little more elaborate on how do we approach seizure and epilepsy, because it's one of the commonest presentation that you see in the emergency as well as in the OPDs, and it is commonly mismanaged as well. The difference between seizure, syncope, or pseudo-seizure, which are functional seizures. So these all points, along with how the seizure occurs, the mechanism of the seizure, what are the clinical features of different types of seizures. For example, generalized seizures, focal seizures, all right? Then what are the recent updates in that? Also investigation, EEG findings, blood investigation, we should do this, and also the treatment. So it will be a comprehensive session. So definitely, I would request you all to please be till the end. All right. So I have tried to make it interactive. I have added some videos as well as some MCQs also are there in this discussion. Okay. So please bear with me in this. Yeah. So myself, Dr. Vishal Gabale, you must have seen my Instagram channel with Viji. I've started this a couple of years back now. I'm also MD, DNB in medicine, MRCP. Also, I'm working as assistant professor now in medicine department in Mumbai. All right, so let's start with discussion. So we will see first MCQ, and then you guys try to attempt those MCQ. Just type the answer in the chat section as well as on the YouTube comment section, and we will see that. Okay. So first question, it's quite easy. What is the key difference between the seizure and the epilepsy? So now, many of you might know, or many of you might not know, that seizure and the epilepsy are two different. Seizure is mostly a single episode, whereas epilepsy most of the times has some underlying structural cause. So that's very classic difference between these two. So let's see what options suffices our need. Okay. So A, seizure refers to single event, whereas epilepsy refers to recurrent seizures due to chronic underlying cause. So that can be a near correct option. So I'll just consider this. Then B option, the seizure is always triggered by metabolic disorder. So it can be triggered by metabolic disorder, but not always. All right. Why epilepsy is caused by structural brain abnormalities. So the answer is both structural brain abnormalities can induce one seizure as well as epilepsy. Okay. So seizure, this is not the answer. Okay. Then C. Let's see C. Epilepsy refers to single seizure. So no, as I said, it's a recurrent seizure. It's a group of recurrent seizure with underlying cause. Whereas seizure refers to multiple events. This is also wrong. A seizure is always convulsive. So that's very, very important point, guys. Seizure is not always convulsive. There is one condition which is called as status epilepticus without convulsion. Okay, SCSC. So here you will not see convulsions, and typically patient has a blank stare or a blank face. Also in neurological cases, if the patient is not able to, we are not able to wean. That means we are not able to put the ventilator off the ventilator, put the patient on the off the ventilator, and patient is not able to recover from the neurological condition. And in this condition, you can say that patient is having this non-convulsive status epilepticus, that is NCSE. Okay, so for this, we do EEG and we have to treat. We just like status epilepticus protocol, lorazepam and all, which we're going to see today. All right, so the answer here is A. I hope with this you got the idea that seizure and epilepsy are two different things. Okay, then second question, what is the incidence of the epilepsy in general population? So this is given a line in the Harrison, just for your reference, 0.3 to 0.5%. All right. So let's see what is seizure, what is epilepsy. Okay. So seizure, as we discussed, is a single episode, okay, of convulsions, right? It can be now due to different causes. All right. Abnormal, excessive, or irritational brain activity, right? Or neuronal activity in the brain. Sorry for the handwriting. Of the brain. I'll try to improvise it by slowly writing it. Okay. So this is the classic definition that's given in the Harrison. Okay. So seizure can, as we discussed, can be different forms. Sometimes it can be convulsive, sometimes non-convulsive. Okay, seizure can also occur because of different reasons. Mostly organic brain disease, or even structural brain disease, even brain injury, even metabolic encephalopathy. Okay, so that was the C option in that MCQ. And as I said, the incidence in general population is 0.3 to 0.5%. And how many people experience at least one seizure in their lifetime? The answer is 5 to 10%. People will have at least one seizure. Will have at least one seizure in their lifetime. Now, why it's important is because you feel that even after one episode of seizure, should we start treatment or not? The answer is obviously no, right? Because single seizure can experience 5 to 10%. So we should look for underlying cause. If it is unprovoked, that means there is no underlying cause, then you might have to start the treatment. We'll discuss that in the treatment. Don't worry about that. All right. Okay. So one more point, the highest incidence of seizures, as you guys must know, okay, highest incidence is in the children's. Okay. So one is small children, young children, and the elderly children or late adulthood. Okay. Late adulthood. So these are the two important indications or two important main causes of the seizure. Now let's see what is epilepsy. So, all right. So as we discuss seizure, the epilepsy is also same. Okay, epilepsy is a group of recurrent seizures due to underlying chronic cause. All right, underlying chronic cause or underlying chronic processes. All right. Also remember, the overall incidence of the epilepsy in the population is 0.3 to 0.5%, and single seizure was 5 to 10%. All right, single seizure. Okay, that's the difference. Okay, yes. And if you talk about per 1,000 people, the incidence given in the Addison is 5 to 30 people per 1,000. All right. Yes, don't worry about the numbers. Nobody's going to ask you this, but that gives an idea, an overview that what to expect from this topic. All right. Now let's see one more MCQ over here. Let's see. Let's dive into the mechanism and pathogenesis. This is very important. You will get one question if you're preparing for either MD, DNB. Okay. Also, if you're preparing for MBBS prof exams. Hands down, you will get one question on the mechanism and the pathogenesis. Also, on the pharmacology. Okay, pharmacology. And if you're preparing for DNB or MD, then also they can ask treatment in detail, particularly surgical treatment. So recently they are also fond of surgical treatment. For example, DBS is also there, corpus callosectomy is there. Okay, temporal lobectomy, all these things are there, which we're going to discuss in the due session. All right, first let's target these MCQs on the mechanism and the pathogenesis. Okay, so here we go. As we can see this question, just a second. Yes. All right. So here, what is the hallmark for the established seizure? Option A, hyperpolarization of the neuronal membrane. Okay, that can be there. That can be there, but it can be seen in all the neuronal mechanisms. All right. So I will just explain the neuronal mechanism as well. But first, let's see the question. Then electrographic spike due to hypersynchronized excitatory burst. Okay, so I will just give you overview about what is seizure versus what is epilepsy. So suppose this is a grass. Okay, this is a grass. You might have seen wildfire. Okay, this is a grass. You can just take it as a brain cell. So what happens during seizure? This particular part of the brain gets activated. Okay, that basically is a spark that acts as a spark in the grass. Okay, dried grass. And now this grass gets gradually spread. This fire gradually spread to all the trees, all the grass in the brain. And that basically will cause epilepsy. Okay, so that basically is a single point where the neuronal mechanism has got problematic, and from there it all starts. Okay, so because of this, you will get this electrographic spike. Okay, due to the hypersynchronized. Synchronized means all these brain cells are working together now as a unit, and because of this, the electric potential of the brain increases, and you have this seizure. Okay, so the answer is electrographic spike due to the hypersynchronized excitatory burst. All right. Now, what is question 2? Which mechanism contributes to the propagation of the seizure? So let's see over here. Increased extracellular potassium blunting hyperpolarization. Okay, yes, this can be. So here there are two things when we talk about the seizure. First was initiation. Okay, sorry for this. Yeah. First was initiation. Initiation of the seizure. That means the seizure will start from that point. And second was propagation. Okay. Second was propagation. So I will explain both of this in the next. Don't worry about that. But the increased extracellular potassium is the start point where the propagation of the seizure occurs. So let's see now how it normally occurs. Okay, so you guys remember the action potential of neuron, all right? So this is minus 70 millivolt. That is resting membrane potential, right? Where your sodium channel, potassium channel are off. Okay? They are both plain. Now, this is your action potential. Okay? Action potential, that is minus 55 millivolt. So at this point, the threshold of the signals reaches, and after that, depolarization occurs in the normal nerves. I'm talking about normal nerves only. Okay, so normally depolarization occurs because of the sodium influx. Okay, sodium channel will open, influx will occur. As we go ahead over here, okay, sodium channel influx will stop, and here potassium influx will stop. Potassium influx will stop. So here potassium influx will stop, sodium influx will stop, right? So because of this, you will get the repolarization. All right, this is all basic stuff you guys know about. Now, what happens normally? Because of the potassium influx, the resting membrane potential or the potential of the nerves goes way below than the resting membrane potential. This part is called as hyperpolarization. And why hyperpolarization is occurring? Hyperpolarization is occurring for a brief period of time. Okay, it's a brief process, not very lengthy process. It's a brief process which occurs because of the potassium influx. Okay. Now, in conditions where there is already high amount of potassium outside the cells, okay, high amount of potassium outside the cells, will this potassium influx occur normally or like properly? No, this hyperpolarization doesn't stops. So it keeps on continuing, and then new depolarization quickly occurs. And basically, because of this hyperpolarization, as it's not able to occur properly, the epilepsy or the neuronal hyperexcitability increases. Okay, so I will just explain with the diagram now. Here we can go. As you can see this, first we have depolarization, which is occurring because of the opening of the sodium channel. All right. Then sodium channel, potassium channel closes. Okay, then potassium channel opens. And here the potassium efflux has started now. And now, after this certain point, there is a hyperpolarization, which is absolutely normal phenomenon and which is seen for the brief amount of time, which is normal. And how it's occurring? It's occurring because of the potassium efflux. But as I said, if there is a high amount of potassium over here, this hyperpolarization will not occur and the cell will quickly go into the depolarization again. And because of this, your neuronal activity increases, leading to seizure initiation. Okay. And this shift of hyperpolarization is called as paroxysmal depolarization shift. Okay, PDS. Don't worry about that. We'll see that now here. Okay. Right. So, first, seizure initiation, how does it start? So, first of all, we have a focal seizure and the generalized seizure, as you know. So, focal seizure, as the name explains. So, first, types of the seizures, as you guys know, is focal and generalized. We will discuss pathophysiology of the same. Generalized. Okay. So, focal and generalized. So, focal, as the name suggests, should start from one point or one specific point. So, just remember, like
recording stopped.
Sorry, what happened? Just a second. Okay. No issues. No issues. No issues.
Recording in progress.
Okay. So yeah, we were talking about how the seizure initiation occurs. So if there is a particularly, you can imagine as a spark in a dry grass. All right. So let's see how it occurs. So first, whenever there is a hyper-excitatory neurons, okay, hyper-excitatory neurons, here seizure initiation will occur. Okay, so how this hyperexcited neurons occurs? This occurs due to the paroxysmal depolarization shift, that is PDS. Okay, and how this PDS occurs, I will tell you the mechanism now. First step, as I said over here, there is no role of calcium normally. Is there any role of calcium? No. But if calcium is acting on this channel, if calcium is acting on this sodium channel, these sodium channels will open for prolonged period. Okay, so that will cause prolonged depolarization. So that's the first thing. Calcium causes prolonged depolarization. Remember all these channels, because you know the pharmacology is basically dependent on all this stuff. So first of all, calcium causes this prolonged depolarization or long depolarization. Second thing, this sodium channels, it basically opens sodium channels, and because of this, you will see the many action potentials will trigger in the nerves. Many action potentials, because of the same reason, as calcium is opening the sodium channels, you will see many action potentials. And finally, as normally, it should end with a hyperpolarization. Okay, normally, it should end with a hyperpolarization. As I said, that hyperpolarization is a normal phenomenon for a brief second. Okay, it's a very brief normally. And normally, potassium channels or potassium efflux will cause this hyperpolarization. All right. And there's one inhibitory neurotransmitter also that has role in this hyperpolarization. So you guys must know this already. That's your GABA. That's your GABA. Okay. So GABA has role in the hyperpolarization via potassium channels. All right. Now let's see how the seizure progression occurs. Okay. Seizure propagation, how is occurs? Just a second. The slide is not good. Yeah, sorry. Okay. So once the seizure has now started, it spreads to nearby neurons very quickly, as we discussed, as a wildfire. So here it spreads by, first of all, by increasing the potassium. So as I said, because of the increase in the potassium outside that neuron or neuronal cell, you will not see hyperpolarization. It blocks hyperpolarization. Got it? Along with that, the calcium that's building up, okay, that causes more neurotransmitters to release. Okay. So calcium has a role in the neurotransmitter release as well. Suppose this is your nerve terminal. Okay. So this nerve, this neurotransmitter is formed over here, and the exit of the neurotransmitter out of the neuronal cell or the neuron in the synapse. This is synapse. Will occur with the help of calcium. Okay. This occurs with the help of calcium and sp2a channels. So from here, these neuronals will go into this. We have two types of receptor over here, NMDA, okay, NMDA and glutamate, and the GABA receptor. Okay, so NMDA and glutamate are the stimulatory. All right, NMDA and glutamate, and here is a GABA. Okay, right. So NMDA and glutamate are the stimulatory the receptors basically, and GABA is the neuroinhibitory. So if they go on this NMDA glutamate, we call it as EPSP. Your EPSP will be produced, and if they go on this, your IPSP or inhibitory postsynaptic potential will produce. Depending on that, your seizure will go ahead. Okay. So if there is no GABA, seizure will continue, or if there is excess of NMDA and glutamate, then also seizure will occur. Okay. So this occurs because of the calcium buildup in the tissues. Okay. As I said, if NMDA receptors, okay, NMDA receptors are open, again, with the help of NMDA receptors, calcium channel rushes in. That means NMDA receptor also is dependent on the calcium. So if it is open, the calcium will come out of the neuron in the neuronal terminal. Okay. Again, because of this calcium, now you know more neurotransmitter will again release in the synapse, and this is called as a vicious cycle. Okay, this is a vicious cycle that you can see in the epilepsy. Along with that, you can also get the emphatic transmission. That means normally if the impulses are going like this, okay, impulses are going like this, due to this process and the mass stimulation of the neurons, there is a directly jumping or saltatory mechanism, right? You guys know this saltatory mechanism. With the help of this, the neuronal hyperexcitability occurs. This is called as emphatic transmission. Okay, emphatic transmission. Yes. Right. And finally, how it will spread to the other part of the brain. So that goes to the what is the largest commissure of the brain? You guys know this. I hope you are understanding the mechanism over here. It's a little complicated. It's given in the Harrison. I've tried to simplify it a bit. Okay. So with the help of corpus callosum, which is a largest commissure. Okay. That means the connection between the brain. It goes from one cerebral hemisphere to the other cerebral hemisphere, and you will have the epilepsy. Okay. So this is your seizure propagation. I hope you understood how the seizure initiation occurred. So seizure initiation occurred due to the hyperpolarization and this calcium, which is stimulating this prolonged depolarization. And here seizure propagation was occurring because of this factor. First is potassium, second is calcium buildup in the neuronal or the neuronal synapses. Then NMDA is open, so it again causes that vicious cycle. Okay, then this emphatic transmission and the corpus callosum helps to spread it faster. All right. So along with that, we have anti-seizure drug action. So as I said, this mechanism is important because we should learn we can learn the medications in the best way if you know the mechanisms. All right. So first, what is the primary action of this anti-seizure drug? So obviously to block the initiation or spread of the seizures. That is the first. And second is to modify ion channels or neurotransmitter activity. Okay, to modify ion channel or neurotransmitter activity. So you guys know what is the ion channel? Sodium, potassium, calcium we have, and neurotransmitter we have NMDA, GABA, and glutamate. So now let's see one by one what are the examples. So sodium channel inhibitor, you guys know phenytoin is there. Right? Phenytoin is there, carbamazepine is there. I will just write CBZ for that. Okay, but very, very important and very, very safe in pregnancy also. That is lamotrigine. Okay. Okay. Phenytoin. So there are a number of the side effects and all. So this is out of the scope of the lecture, but still like at the end of the lecture, I've added one chart where we can summarize the side effects and all. But here, I just want to tell you that just on the basis of pathophysiology mechanism, what are the drugs? Okay. So sodium channel, phenytoin, carbamazepine, lamotrigine. Now calcium, you guys must know this. Very, very important. You guys use this in a couple of other indications as well, like for example, neuropathy. Okay, so gabapentin, pregabalin. Okay, pregabalin. This is commonly asked questions in your Viva. Very, very important for the MBBS students, particularly. Also for the MD, DNB for Vivas. All right. Then potassium. So potassium. So we have newer drug that's slightly newer, ezogabine. Okay, ezogabine is there. For glutamate attenuation, we have topiramate. Very important. Topiramate is there also. Newer one, that is perampanel. Okay, perampanel. Okay, perampanel. P-E-R-A-M-P-A-N-E-L. Perampanel. Okay, then GABA. For GABA, we have benzodiazepines, barbiturates. All right. And lastly, we have synaptic vesicle modulation. That is your SVA2. And for that, we have levetiracetam. Okay, levetiracetam. This is also one of the safe drugs. Okay, lamotrigine and carbamazepine can have the Stevens-Johnson syndrome-like features. These are like important side effects for this. Even phenytoin has a n number of the side effects. Okay. Then BZD barbiturates also has liver toxicity, hepatotoxicity. Levetiracetam also one of the safe drugs. Okay, so these are some anti-seizure drugs. We will discuss that detail in the treatment part. Okay, so along with this pathogenesis, we have some important factors that plays like important role in the spreading of the epilepsy. So that is called as epileptogenesis. So because there are several factors, not only this mechanism, there are some risk factor or also called as epileptogenic factor or precipitating factor. For example, if somebody is having fever, A kid is having fever, you will get epilepsy, right? Somebody is having head injury, that will act as an epileptogenesis factor. So we will discuss that with this MCQ. So which of the following is an example of the epileptogenic factor? All right, so many people will feel high fever in the children is epileptogenic factor, but no, that's a precipitating factor. Epileptogenetic means organic damage to the brain. Okay, so severe penetrating head trauma, yes, that can be one. Stress or sleep deprivation, no, that's also a precipitating factor. Intermittent photic stimulation, that means like photophobia or something, light, that's also not. Okay, so the answer is severe penetrating head trauma, that's an epileptogenic factor. Now, second question, what is the term for the process by which normal neuronal networks are transformed into abnormally hyperexcitable ones? So this term is very important. This is basically your epileptogenesis, right? So epileptogenetic factor will obviously cause the epileptogenesis. That means the normal and neuronal, normal neurons will work as a dynamite, basically, will work together for the hyperexcitability and for the seizures. So that occurs because of the epileptogenic factors. So let's see those. Okay, so epileptogenesis is the transformation of the normal neuronal networks into the hyperexcitability ones. I hope you got it. Okay, also because of the structural and biochemical changes. Now, progression of the epilepsy. Okay, so that will occur because of delay between the CNS injury and the seizures. Okay, so you might have seen sometimes just after CNS injury, you don't get seizures. There is some time. So that is called as this progression. That time between the CNS injury and the seizure, where there are structural reorganization and the inflammation reduces the seizure threshold. Okay, so then we have genetic causes, right? So genetic causes because of the mutation, the sodium channel, potassium channel can also cause this. Okay, then mechanism of the drug action. So we have already seen that sodium, potassium, we can give sodium calcium channel inhibitor and how to prevent the seizures. And finally, there are some specialized drugs which works in some unique way, and we will see that in the treatment part as well. And current gap is, so we can reduce the seizure, but we cannot stop the pathogenesis, or we cannot stop the organic damage to the brain. So we have lack of this anti-epileptogenic drugs. For example, if somebody is having brain injury, we can't give any drug to not damage brain. We can just give prevention or prophylactic anti-epileptic. Okay, so that's under something we just study. So with this is tabular summary for the same thing. Now let's see what are the common subtypes or common causes of the epilepsy based on different age group. All right, so first is this, which of the following is not a common cause of seizure during the neonatal period? So you guys already know this. It's a very easy and very simple and logical, as you can see over here. First is hypoxic ischemic encephalopathy. Yes, it can be a case. Hypoglycemia, yes, it can happen. Neurodegenerative disorders, you guys can obviously tell it's mostly seen in the adults. That's the answer. And the paradoxin deficiency can also seen in the children. So that's not the answer. So C is the answer. Now, when do seizures due to inborn errors of metabolism occurs? All right. This is one question which will come back after the discussion. Let's see now. Okay, so first, febrile seizures is one of the commonest type of the seizure. And here, it occurs because of the fever. Right? You guys know fever will occur, and it's one of the precipitating factor. The number of the patient it has is 3 to 5%. All right, it's very common. Along with this, age range for this is 3 months to 5 years. That means peak childhood around 2 years. Sorry, around 2 years is a peak age or peak age of this. Okay, then we have simple febrile seizures and the complex febrile seizure. That means if it's repeated, if it's more than 15 minutes, if the it's focal, particularly at one point only after fever. That's your complex. And if it's generalized, okay, generalized, tonic-clonic, and if there is no risk of epilepsy, then you think that there is a simple febrile seizure. So it's slightly contradictory as the name suggests. So simple febrile seizure is mostly a GTCS, whereas complex febrile seizure is the focal seizure. So this is one of the commonest MCQ you can expect in the exams. Okay, that they will write or ask the question, which of the following about the simple febrile seizure is wrong? First, it's single. Second, it's brief. Third, it's symmetric. And fourth, it's focal. So it is not focal, it is a generalized. And focal is the complex febrile seizure. I hope you understood. Now, triggers. Rapid temperature rise during the common infections. It can be otitis media, respiratory infection, okay, common viral fever, anything can be the cause. All right. So you have to just look for those factors when we talk about the febrile seizures. So I think it's more elaborative because I tried to cover entire Harrison that's talk about the epilepsy. So if you want, you can just watch at 1.5x if it helps. All right. Then talking about the childhood epilepsy now. So most of the time in childhood epilepsy, you will have GTCS, that's idiopathic. Along with that, if patient develops epilepsy in the childhood, it can also cause developmental abnormality. CNS can also be underlying causes like CNS, TB or meningitis. Okay, so trauma, CNS infection, even developmental disorders can be causes for this childhood epilepsy. Okay, even temporal lobe epilepsy, that's your basal temporal sclerosis, that can also be one of the cause, and it's refractory, difficult to treat this. Okay, so these are the some variants. So now, as you can see, based on the age group, you have the different causes of epilepsy. All right, so we will see one by one. The first is neonates. As you can see in neonates, mostly perinatal hypoxia ischemia. That was in the option, right? Very important. Intracranial hemorrhage trauma can be there. CNS infection, yes. Metabolic disturbances like hypoglycemia, that was in the option. Hypocalcemia can also cause, okay, not hypercalcemia. Okay, hypomagnesemia, not hypomagnesemia. So this is very important point. Remember, whenever you are solving MCQ or reading any point in theory examination, whenever you get hypermagnesemia or hypocalcemia, make a habit to just remember it as not a hypermagnesemia or not a hypocalcemia, not a hypercalcemia. So in that way, you tend to less forget these things, okay, and make less mistakes in the exams as well. Okay, so hypocalcemia, hypomagnesemia, pyridoxine deficiency, that was also an option, right? Also, it can also be associated with the drug withdrawal, developmental disorders, and genetic disorders. Okay, like mitochondrial encephalopathies, etc. You can see this. Then now coming to the infants and children, that is less than 12 years. Okay, one month to 12 years. So here febrile seizures are very common, around 24 months, 12 to 24 months. Yes. Along with that, genetic disorders like metabolic degenerative primary epilepsy syndromes are seen with CNS infections, developmental disorders, and trauma. Okay, so I'm not going into the depth because you guys know if you talk in detail about that, we'll get into the pediatrics aspect. Okay, then coming to the adolescents now. In adolescents, mostly trauma, genetic disorders, infections, illicit drug use. Okay, for example, morphine or cocaine-induced, even benzodiazepine abuse. All these things can cause. Along with that, in young adults, trauma, alcohol withdrawal, very important. Here also illicit drug, alcohol. Okay, then illicit drug use, brain tumor, autoantibodies. Okay, autoantibodies, that means autoimmune phenomena. You can say it's as autoimmune encephalopathy. Okay, this can cause or CNS, lupus or something like that. Then coming to the older adults. Now this is the MCQ. In older adults, cerebrovascular disease. Okay, this is very important. Almost 50% of the older adults having seizure is because of the cerebrovascular disease. In that also the embolic is more. Okay, embolic is more than the thrombotic. Okay, why I'm writing this now? It's very important. Suppose you get any patient with adult epilepsy, you can expect 50% of the times it must be cerebrovascular disease. So go for MRI without fail. Don't just give anti-epileptic and waste your time. Go for MRI, see if there is any lesion or not. If patient is in the window period, as you know, the window period is 4.5 hours for thrombolysis in case of stroke. So if you go in that time zone, you can thrombolyze and save the patient or save the penumbra. But, and also if you get the cause now and patient is not into the zone, then as you know that it's embolic. So the second thing you ask is 2D echo. Okay, because the cardioembolic phenomenon can be a cause. So just check the patient is having any LA clot, etc. Okay, and that's causing this this type of embolism. Okay, or if you can check ECG as well, it will give you idea atrial fibrillation, etc. can be seen. Okay, so that these are for echo for the LA clot and ECG for the atrial fibrillation. Okay, so that's how you have to approach based on the age group of the patient. Along with that, obviously, when you do the MRI, we have to rule out brain tumor. Alcohol withdrawal is very important point. Okay, metabolic disorders like uremia, one of the important cause in case of CKD patients, hepatic failure in alcoholic patient or CLD patient for hepatic encephalopathy, electrolyte abnormalities like hyponatremia is very common. Okay, hyponatremia is very common. Then hypoglycemia, again, most important. You have to check this in metabolic profiles. Okay, so while before you send the patient to the MR, always have an habit to send the metabolic profile of the person. Okay, metabolic profile. So in that you can say LFT, RFT. Okay, yes. Now finally, in case of some degenerative disorders, because of the atrophy of the brain, sometimes there is a scar formation, and because of that, you can have epilepsy like Alzheimer's disease or other neurodegenerative diseases. Even autoantibodies, for example, anti-NMD antibodies, which is mostly seen in the autoimmune encephalopathy. Okay, so these are some of the causes. I hope you understood each and every aspect about this. Right now, let's see adolescence and the early adulthood as we discuss the causes. So in early adulthood or adolescence, sorry, you will have the juvenile myoclonic epilepsy. Very, very important cause. We will see it in the epilepsy syndromes. Okay, then juvenile absence epilepsy. Also, we will discuss that in the epilepsy syndromes. Okay, then acquired causes like head trauma, CNS infection, drug use like alcohol, even autoimmune epilepsy. For example, potassium channel glutamate receptors, autoimmune channels can. Now, in case of older adults, as we discussed, cerebrovascular disease, 50% of the cases are because of that. Embolic strokes are more common. Hemorrhagic strokes are also common. Then trauma includes the subdural hematoma. Okay, any types of trauma, subdural hematoma, subarachnoid hemorrhage, etc. Coming to the chronic seizures now, it can occur after the stroke or trauma for a longer period of time because of the scars. Okay, that some people also call scar epilepsy. Okay, scar epilepsy. Treatment here is only most of the time is anti-epileptics. Most of the time you can't treat it. All right, I mean there is no definitive treatment. Then metabolic and systemic causes, as we already discussed, send a metabolic profile, check for hyponatremia, check for hypomagnesemia, hyperglycemia, very, very important, hepatic failure, renal failure, to check ammonia, to check uremia. All these are the important things. Then medication and substances, check for alcohol, cocaine, morphine, other agents. Okay, amphetamine is very, very important. That also has these effects. Benzodiazepine abuse. Okay, so all these are related with the epilepsy. Nice, right? So now let's see some MCQ, and then we will discuss the clinical features. Okay. So which of the following is the characteristic of the simple febrile seizure? So you guys can say this now. Last more than 15 minutes. It's a focal feature. No. Occurs as a single isolated event and associated with the high risk of epilepsy. So the answer would be this. Occurs as a single and isolated event usually. That's your simple febrile seizure. If it's occurring recurrently, if it lasts more than 15 minutes, then it should be a complex febrile seizure. Very, very important MCQ point, okay? For all the entrances you are preparing, whatever it may be. Okay. Then what is the most common cause of seizure in the older adults? You guys know now cerebrovascular disease. Okay, 50% of the cases. Okay. Right. Which now let's see the classification. Now, this is the 2017 International League Against Epilepsy classification. Okay. So in 2017, they said that epilepsy earlier, it was partial epilepsy. Okay. And then or partial seizures, complex seizures was the earlier term. In 2017, they said, don't use that. Use focal and generalized seizure, or focal onset seizure, generalized onset seizure. But now they're saying, don't use the word onset itself because we are not very sure about the onset from where it's occurring. But let's speak only focal seizure. That means a particular part of the brain is localized. So you can just say focal seizures now. Okay, so focal seizures, generalized seizures. Okay, unknown onset is okay, different thing. That's a different category now. Motor, non-motor, they are categorized into the different aspect. Okay, so that's a 2025 International League Against Epilepsy classification. And that's yet to come into the Harrison, so not covered that in detail. All right. So according to the 2017, we have focal and generalized. Okay, so focal and generalized. So now things are gonna get a little interesting because I have a videos for you. And you guys have to identify that what it could be. Okay, I'll be seeing your reply in the chat section. Okay, I think chat section is on. Let's hope that you guys are able to answer this. Okay, so first, let's see the classification, focal versus generalized. So see, in focal, you have the focal seizure of two types, first and second. So first type is focal seizure with impaired awareness. Okay, so focal seizure with impaired awareness. Impaired awareness. Here, patient will have focal seizure. Okay, for example, if somebody is having, it can be anything, motor, or it can be autonomic, neurology, or sensory, anything can be there. Most of the times, lip smacking is there, chewing is there, or hand movement is there. Along with that, this patient most of the time also have the aura. Okay, aura is also there. So what is aura? That aura is different. What you guys see reels on Instagram and all, that's different. Here the aura means strange feeling of smell, or you can have the strange sensation. Okay, don't ask case sensation, right? So here we go. So that is your impaired awareness. Focal seizure with impaired awareness, and here focal seizure with intact awareness. So here patient will have the conscious awareness about the surrounding. For example, somebody is having eye seizure, like this. This is they are more doing the movement of the eye, and you ask the patient to lift the left hand, they will lift the left hand. You will ask the patient to lift the right hand, you ask the patient to sit, they will be able to sit. So that's your focal seizure with intact awareness. And generalized seizure, so you guys know this. Generalized seizure mostly are of 2-3 types. I will just mention it over. GTCS is there. Generalized tonic-clonic seizure, where whole body is involved. That's your first. Second is atonic seizure. Atonic seizure. Atonic seizure means body will suddenly lose the tone. That means person will just, he was just doing activity like this and suddenly will go down like this. That's atonia. Okay. And third is your absence seizure. That means person is just looking at something, takes blank period of time like this, and suddenly comes back. Okay, what I'm saying? That's substantiation, right? So now let's see some important things about this. Okay, so let's start with the focal seizure. So on the basis of whatever I told you right till now, I hope you will be able to answer this question. Let's see. Which of the following is not a characteristic of focal seizure with intact awareness? Okay, so intact awareness is there. That means patient is able to interact with the environment. That would be a proper word as per the Harrison. Okay, here patient is able to able to interact with the environment. So motor manifestations such as tonic, clonic, or myoclonic moments can be seen. Okay, they have asked for the not. Sensory symptoms like paresthesia or visual hallucinations. Okay, impaired awareness and automatism. So this is a very, very easy answer for you all, right? They are talking about the intact awareness and they have already given here impaired awareness. So just if it was automatism, then it would have been slightly trickier. The answer is C anyway. But remember, the automatism is the part of the impaired awareness group. Okay, not the intact awareness group. Okay, along with that, a Jacksonian march is also one important feature. That means progression of the motor activity to the entire body. That means if the seizure is starting from this one hand, I'm having this seizure right now, for example, then after some period of time, I will have seizure in my legs, seizure in my left hand. Okay, so that's called as Jacksonian march. There is one more also term. If this seizure keeps on continuing, usually focal seizure should stop. But if they keeps on continuing for more than 24 hours, that's called as epilepsia partia continua. That means these seizures are continued. And also, after seizure, if I'm having paralysis or paralysis, that's called as Todd's paralysis. Okay, so these are all features of focal seizure with intact awareness. Now let's see a video. You guys tell me what is this type of the seizure. Okay, let's see here. Just look at this. Yes, these are focal seizures, no doubt. She's trying to talk to him. So what do you think? What do you think, guys? Yes, it was focal seizure with impaired awareness. All right. So let's start the classification of the focal seizure with impaired awareness. All right. That means let's start with the focal seizure. So as we discussed in focal seizure, it usually starts from one point. Okay. So effect on awareness, as we discussed, can be intact or impaired, and nature of onset can be either it can be motor, that means initially involving the hand movement like this in that patient you just saw. Either can be non-motor, for example, sometimes emotional symptoms, aura, etc. All these things can be there. Or in focal seizure, usually gradually they can progress to the generalized seizure also. Now here is one more video just to let you know the difference between the two. So please see this now.
उठाओ, दाहिना हाथ उठाओ। बायां हाथ उठाओ।
They're asking him to, her to raise the hand now, left hand. Now asking to stand, let her stand, walk. So as you can see, she is able to obey all the command. So that's a partial seizure with the intact awareness. Okay. So let's start with partial seizure, or sorry, not partial, focal seizure. Partial seizure is not used now. So focal seizure with intact awareness. Okay. So what are the features in that? It can be tonic-clonic or myoclonic moment. You can have any type of moment, and focal seizure here involve the may also involve the contralateral side of the body only. And for example, so this is one question that's they're giving. Example they're giving. If the seizure is starting from right motor cortex, you can have involuntary movement in the left hand, possibly the face. Okay, so that will be a localization of this focal seizure. So along with that, not only motor movement can be seen in the focal seizure, it can also be non-motor. For example, sensory symptoms some of the times. Okay, so what are the sensory symptoms? So as we just said, that sometimes feeling of all the sensations, smell, etc., all these things can be there. Okay, so this can be a thing. Okay, just a second. Yeah. So if you talk about the sensory, you can have the paresthesias, tingling, numbness, anything can be there. Okay, tingling, numbness, even flashing lights, even hallucinations. Okay. Hallucination. These features can be there in the form of sensory. Along with that, autonomic in the form of feeling a sense of falling or vertigo, even changing in heart rate, sweating, pylorexia, okay, goosebumps and all those things, what you expect that can be there in the focal seizure with the intact awareness. Okay, so focal seizure can be of motor as well as non-motor also manifestations. Okay, along with that, emotional symptoms like fear, that person will get scared, then deja vu. Deja vu means that's something he will feel that, yeah, this lecture has already happened and I'm watching it again. Okay. Depersonalization. That means that I'm not this person or this person doesn't belong to me. Okay. All these things can happen. Yes. That means depersonalization particularly means that you will feel isolated from the surrounding, that, yes, this is not me here exactly. Okay. Yes. So all these are emotional symptoms that can be a part of the focal seizure with the intact awareness. Okay. So apart from that, as I mentioned, the focal seizures can be of other things also. The three important phenomena can be seen in the focal seizure with intact awareness. First is Jacksonian march, which I already explained. That means the seizures can go to the other parts of the body as well. That's a Jacksonian march. Then torch paralysis. After this focal seizure, you can have the paralysis. What's your torch palsy? And epilepsy partial control. That means even the seizure keeps on continuing for hours or days, and it's refractory to treatment. Okay, so these three important things are related to the focal seizure with the intact awareness. Okay, now coming to this video, just let's see. Yeah, this is the same video what we just saw. Okay. Yeah, now look at this person. He's starting with the mouth movement. Now there is also hand movement that's called as hand fidgeting on the clothes. Okay, that's a hand movement. She's trying to make her comfortable a bit. And as you can see, he is not conscious oriented. He is not able to understand. Now he just suddenly comes back to the orientation and he asks her that, did I again had a seizure? Then she said, yes, you just had a seizure. So he realizes, okay, I had a focal seizure with an impaired awareness. Okay, he only knows this because he has watched this lecture. Right? So then, as I said, that focal seizure with impaired awareness will have the aura. That's very important point. As the aura, as I mentioned, there will be unusual sensation or feeling before progressing to the ictal phase. So that sensation can be of some smell, okay, some sort of strange smell or strange feeling can be there. Okay, that can be any form of the aura. Along with that, it usually starts with a motionless stare. Okay, now what are the automatisms that can be seen in this type of seizure? So as you just saw in that person, he was having involuntary repetitive movement of lip smacking. Okay, where you smack the lip with the teeth, you smacking, then chewing. Basically you might have seen these patients in your OPD as well. I've seen several types of these videos as well, where suddenly patient comes and starts chewing. So one day this patient came to me and I asked that, like, what are you eating in the OPD? Then the father explained me, doctor, it happens to him we also feel like he's eating something or something like that, but that's a habit he has got. And when he's doing that, he is not able to understand what we talk to him. So that's basically your focal seizure with the impaired awareness, where chewing can also be seen, swallowing can also be seen, and even hand movements, either hand fidgeting or head banging, any types of these movements can be seen. All right. So if sometimes even patient starts running here and there. Okay, so as you can see over here, more elaborate behaviors can include running or emotional displays. Okay, suddenly he starts crying, or sometimes he starts running here and there and doesn't understand anything. Okay, so that can be a very rare, but yes, that can be there. Now, after this seizure, patient is often confused because it's a impaired awareness, right? And sometimes post-ictal deficits can also be seen. That means he will not be able to recall that where I was, what happened to me, exactly why I am here. Okay, even there will be anterograde amnesia. Anterograde amnesia means he will not be able to form new memories. Okay, so these features can be there. Now, that's all about the focal seizures. I hope you understood it. Okay, now we will start with the generalized seizure and how the evolution of the focal seizure to generalized seizure occurs. So as I mentioned, focal seizure is restricted to one part of the brain. Okay, so focal seizure to generalized seizure will occur obviously when the seizure goes from the one part of the brain to the both cerebral hemispheres. That will cause the generalized seizure. All right. Now let's see how do we differentiate on the basis of EEG, electroencephalogram, or the different types of seizure. So as you can see over there, in focal seizure, the rest of the brain activity is okay, and some you are having this sudden episode over here, and again the brain activity can get back to normal. So this is your focal seizure. Whereas in case of generalized seizure, the brain activity is quite chaotic. All right, it is persistently chaotic. So that is your generalized seizure. Okay. So when we do this interictal and ictal EEG, we get this type of features in case of focal and generalized seizures. Now, let's start with the generalized onset seizure. So right now we don't use this word onset as I said. So let's see this MCQ. Which of the following is the main seizure type in 50 to 20% of the children with epilepsy? Anybody wants to attempt this question? If you feel GTCS, you are wrong. It's typical absence seizure. It's one of the commonest in the children's. Okay, 15 to 20%. Then, which of the following EEG finding is the characteristic of typical seizure? So we are talking about typical absence seizures here, not atypical. Okay, typical. That means patient will have typical EEG finding. So as we have learned since our childhood, that 3 Hz spike and slow wave discharges will be in the typical absence seizures. So if it's atypical absence seizures, here you will have slow spike and slow wave pattern. That's less than 2.5 Hz. Okay, so the answer here is C. Now, third question. Which seizure type is the most commonly associated with the drop attacks? So this is a very classic question for entrance exams. So atonic seizures. Where suddenly a patient will drop like this. Okay. Yes. So generalized seizure, we will see now one by one. First is generalized absence seizure. Okay. So as I said, generalized usually starts from one point of brain and then spreads and rapidly involves both cerebral hemispheres. Okay. So first is typical absence seizure. Okay, typical absence seizure usually lasts for seconds. There is a sudden loss of consciousness, as I mentioned. Suppose I am taking a lecture over here and suddenly I pause for a second. And then I said, okay, what we were discussing, that's your absence seizure. Most commonly, it's the commonest complaint of the parents is the reduction or the decrease in the scholastic performance of the kid. Okay, where the person was able to perform well now, or the kid was able to get good marks earlier phase. Now, since few days, his attention and everything suddenly is having this strange moments and his performance is getting down. So that's your typical absence seizures. So now let's see what are the features of typical absence seizures. Then we will compare it with the atypical absence seizures. So typical absence seizures, we will have rapid eyelid blinking, chewing moments, even small hand clonic moments can be there. Age of onset, as we see, it's usual in the childhood. 4 to 10 years or early adolescence can also be there. Okay, frequency, it can be hundreds of times per day. EEG, 3 Hz spike and slow wave discharges like this. Okay, so as we can see over here, so initially it was okay, but now 3 Hz, that's the frequency. Okay, 3 cycles per minute. It's a second, sorry, 3 cycles per second. That's the 3 Hz. Okay, also called as 3 Hz spike and slow wave discharges. That is typical for that, and it is often mistaken as attention deficit disorder. So why it happens usually? the kid was performing better. Now he is having absence seizure. Suddenly parents feel that why it's not getting why it's not performing better. Does he have different things in his mind? Kids also, after having this absence seizure, try to suppress it by overperforming things, by asking questions or moving here or there randomly. So that can get this that can lead to this underdiagnosis or misdiagnosis with the ADHD. Okay. Then finally, clinical presentation may present as a daydreaming or decline in the school performance. Yes. Sorry for this. Just a second. So now we have just seen the typical absence seizure that was brief for a few seconds. Atypical absence seizures are long duration and they are less abrupt onset compared to the typical absence seizure. Okay. Symptoms are more obvious in this case, may include focal or lateralizing features are also there. And EEG will have the slow spike and slow wave discharge, but less than 2.5 hours. Okay, and also it can be associated with the mental retardation, brain abnormalities, poor response to anticonvulsants. Okay, so that's few of the features. So remember, the longer duration is the differentiating factor between the typical and atypical along with the EEG finding. Okay. And also motor symptoms are more obvious in the atypical absence seizure. Okay, so now you guys tell me what is this type of seizure. As we're discussing generalized seizure, just tell me what is this. So this is a very, very important and common type of the generalized seizure. This is your GTCS. That is your generalized tonic-clonic seizure. Okay. So this is your generalized tonic-clonic seizure. Here, whole body will go into the contraction or clonus, what we say, and the tone of the muscles will also improve. Hypertonia will occur. Okay. So it is an abrupt onset, may have vague premonitory symptoms sometimes, and tonic phase can also occur, and clonic phase can also occur. So both phases are usually there. So what is tonic phase? The muscle contraction will occur, loss of respiration, ictal cry, cyanosis. Ictal cry means there is a conjunctival tearing. Then cyanosis, tongue biting. It's a very, very classic feature for this. Okay, so this is a differentiating feature between the seizure and the syncope. Seizure versus syncope. Okay, so many times patient comes, with a history of unconsciousness or brought by the relatives with a history of unconsciousness. Now, if patient doesn't have tongue bite or you don't get ictal cry, etc., then in these cases, or if you get the frothing of the mouth, these are mostly suggestive of the GTCS or the seizures than the syncope, which we'll discuss in the history part next. Okay, so those things, tonic phase, both will be there. Tonic phase is alternating muscle relaxation and the contraction. Okay, apart from that, there will be post-ictal phase, which will not be in the syncope again, in which confusion, muscle flaccidity, excessive salivation, incontinence is also one of the important feature that's seen in the seizure, which is not seen in the syncope. Okay, that is one more differentiating feature between seizure and syncope. Along with that, if you check the EEG, you will have slow voltage, fast activity, followed by polyspike discharges, high amplitude, and spike and slow wave pattern can be seen in the clonic phase. Okay, so there are some syndromes that includes this. So one of the examples is Lennox-Gastaut syndrome, which we'll discuss in the epilepsy syndromes. Okay, so that's all about the GTCS. Got it? Now, what is this type of seizure now? Just see this video. So these kids are discussing few things in their class. Suddenly something happens. Just look at this kid with the helmet. Yeah, see what's happening with him. Right? So he's completely losing the tone of his body. All right. So that's your atonic seizures. Okay. So there is a sudden loss of the postural tone, often causing the fall. That's called as drop attack. It's a classic feature. Duration is only 1 to 2 seconds. And here it's a generalized seizure. Right? EEG can have generalized spike and wave discharges followed by the diffuse slow waves. Now you understood why he is wearing helmet, because he's having frequent atonic seizure. So the schooling has to be so important, and the epilepsy education has to be so important in these cases to prevent the head injuries. Also, the awareness among the other students and the teacher itself is really motivating. Okay. Right. Now there's one more seizure, which is also one of the generalized seizure. Let's see this. Oh, what's happening? See, she's having muscular contraction. Now she's getting back to normal. So that's your myoclonic seizure. Okay, myoclonic seizure. Okay, yes. So myoclonic seizure are sudden brief muscle contraction affecting one or more body parts, and EEG has bilaterally synchronous spike and slow wave pattern in this case. Okay, and it is associated with the juvenile myoclonic epilepsy and other generalized seizures. Now, final part of the generalized seizures is the epileptic spasms. Okay, so what are those epileptic spasms? So it has characteristics like sustained flexion or extension of the proximal muscles, particularly in the infants, mostly seen in the infants, and this EEG finding that is called as hypsrhythmia. Okay, that is diffuse giant slow waves and the irregular spikes, as we can see over there. Okay, giant slow waves are there, irregular pattern of the EEG. It's a classical hypsrhythmia, and that's seen in the epileptic spasm. And if you do the myography, electromyography, because of this myoclonic epilepsy or myoclonic jerks, you will have the rhomboid pattern in the EMG, and you can make the diagnosis of the myoclonic seizures with the help of them. Okay, epileptic spasm, mostly seen in the pediatric population, so don't worry about this much. Okay, so this is a summary of things just we discussed. Typical absence seizure is a sudden, brief. Atypical is, atypical is a longer lapse of the consciousness. EEG feature in the typical is 3 hertz. Here it is less than 2.5 volts. GTCS, as we discussed, can have tonic as well as clonic phase. Atonic, as we discussed, only few seconds, and it has also the same thing, spike slow and followed by diffuse slow waves. Myoclonic seizures mostly seen in the children. Brief muscle contraction and bilateral synchronous spike and slow wave discharges can be seen, associated with the juvenile myoclonic epilepsy. And epileptic spasm has the hypsrhythmia. That means a sudden, brief, slow, high amplitude EEG waves. Okay, those can be the features mostly seen in the infants. Okay, so these are the summary of the generalized seizure. Now, very MCQ important point, that is epilepsy syndrome. So let's see that. So in that we have 3 MCQ. Which of the following is the key characteristic feature of juvenile myoclonic epilepsy? So I think before that we'll just discuss the syndromes and then we will come back to these questions. Okay, so that will make a better understanding. Yeah. So first is juvenile myoclonic epilepsy. As the name suggests, it's a juvenile myoclonic, means muscle spasm will be there. Okay, so let's see that. It's mostly seen in the early adolescents, as the name suggests, juvenile. Key clinical features: bilateral myoclonic jerks, as the name suggests, again, usually occurs in the morning and after awakening. This is a very important point. Okay, usually occurs after the morning and after awakening, because all the neurotransmitter, all the impulse, all the nerves, etc., have their own good amount of the calcium in the muscles and all can cause muscle spasmism. Okay, the seizure type it has. So one important misnomer or one important mistake students do is while doing this question now, they feel that juvenile myoclonic epilepsy must have only myoclonic seizures, but no, it can have even GTCS and can also have the absence seizures. Okay, so that's very important point you should know. So in case of juvenile myoclonic epilepsy, if they ask which of the following, sorry for this, I don't know what's happening. Yeah. So in case of JME, if they ask which of the following statement is wrong, it is seen in the early adolescence, it is mostly seen in morning, it also includes myoclonic seizure, it also includes absence seizures. So all of them are correct, right? Because it includes myoclonic seizure, generalized seizure, absence seizures. All of these are included in this. All right. One. While talking about the provocative factors now, yes, sleep deprivation is the provocative factor that was given in the question. If they talk about the consciousness, yes, it is preserved unless myoclonus is very severe, and prognosis remission is very rare in these cases. Well, seizure can respond well to anticonvulsants. Okay, and genetic factors are important in this case, right? That is juvenile myoclonic epilepsy. Next syndrome, very important, Lennox-Gastaut syndrome. Here you will have the triad of multiple seizure type. Again, you can have GTCS, you can have Atonic seizure, you can have a typical absence seizure, and impaired cognitive function. Okay, so you can have first is seizure, then EEG changes in the form of less than 3 hertz slow spike wave changes. And third is impaired cognition. This is a triad of the Lennox-Gastaut syndrome that you should know. Okay, LGS. All right. So I hope you understood this. Okay, mostly seen in the childhood, and EEG shows less than 3 hertz spike and wave discharges. Now, what are the causes for this? Obviously, CNS dysfunction, for example, de novo mutation, developmental abnormalities, trauma, infections, even multifactorial causes can be there, which are non-specific. Okay. Then prognosis is poor in this case due to severe epilepsy and underlying CNS disease. Okay, so I hope you understood what is Lennox-Gastaut syndrome. Now, final. So then we have mesial temporal epilepsy. Okay, mesial temporal lobe epilepsy. Here, typically, you will have this type of corpus callosal involvement. Okay, sorry, hippocampal involvement. Okay, hippocampus is involved in these cases, leading to hippocampal sclerosis. That's a classic feature of the MTLE. MTLE is one of the refractory type of seizure. Okay, so it's a focal seizure with impairment of the consciousness. Impairment of the consciousness is the key feature. Along with that, on MRI, you will have the hippocampal sclerosis. Okay. Prognosis, as I said, it is often refractory to the anticonvulsant treatment. And surgery, we have to do hippocampectomy for this. Okay. It's very easy to remember this. I hope, you know, these are some key points that's given in the ISN about this. And you have to remember only this for your exams. Okay. So it has impairment of the consciousness. Second, it causes hippocampal sclerosis. Third thing, it's refractory to the anticonvulsant treatment. And fourth, this surgery is the mainstay of treatment. Okay. Then pathophysiology, as I said, hippocampal sclerosis is often essential for many patients with MTLE, and it's still under the study. Okay. Yes. Now, this is one more chart that's given in the Harrison about the MTLE. The same thing as we just discussed. Patient can have either history of febrile seizure. Okay, and just zoom. Febrile seizure history is there. Generalized seizures can also be there, and they can remit, reappear, and often intractable early onset seizures can be there. On clinical observation, you can get aura, behavioral, arrest, stare, complex automatisms can be seen because it's a focal with impaired awareness, basically. Okay, and that is, we are discussing epilepsy syndromes. Okay, we are not discussing generalized seizures. Generalized seizure is over. We are discussing epilepsy syndromes, in which we have discussed 3 till now. Okay, Lennox-Gastaut syndrome is there, then mesial temporal epilepsy is there, and the first one. Okay. Now let's see this. In this, we have laboratory studies where there is a bilateral anterior temporal spikes on the EEG, hypermetabolism, hyperperfusion on the ictal SPECT scan at the hippocampus. Then MRI will show small hippocampus with increased signal, and because of the loss of the trigeminal hippocampal architecture, leading to, you can just say, hippocampal sclerosis. Okay, so that's all about this MTLE. And now let's go and see this question. Okay, so first one is about the first epilepsy syndrome, that is juvenile myoclonic epilepsy. And as the name suggests, it is seen in the children's. Myoclonic means it can have different, not only myoclonic, but different types of seizures can be there. Okay, so let's see now. What is the key characteristic of JME? Does it have only generalized tonic-clonic seizures? The answer is no. It can have different types of seizures. Does it have bilateral myoclonic jerks, often provoked by sleep deprivation? Yes, it has this. Presence of atonic seizure? Yes. Okay, no atonic seizures. Okay. Atonic seizure is included into the Lennox-Gastaut syndrome. Okay. In case of JME, you will have myoclonic seizures. You will have absence seizures. And you will have GTCS. Right. So this is also not the case. That significant decline in the cognitive function? No. It is the feature of the LGS, Lennox-Gastaut syndrome. All right. So I hope you understood. Bilateral myoclonic jerks often provoked by sleep deprivation. That is a juvenile myoclonic epilepsy. Second question. Lennox-Gastaut syndrome is most commonly associated with which of the following? So A, single type of seizure, tonic-clonic only. So is this the case? No. Slow, less than 3 years, spike and wave pattern? Yes, it can be a case. Absence seizure with complete remission? No. Non-epileptic causes of the brain dysfunction? No. All right. So it is most commonly associated with less than 3 years spike wave patterns. Now let's see which of the following is the characteristic of the MTLE. Now here, generalized seizure with loss of consciousness, yes, can be there. Hippocampal sclerosis observed by MRI. This is one of the class characteristic feature of this. Okay, so that will be answer. Right. So here we go. It is the characteristic slow less than 3 hours, 5 can be discharges we have seen. And here it has the focal seizure with impaired consciousness, but the characteristic feature is hippocampal sclerosis on the MRI. All right. Then coming to the history now, history and examination point, then we have investigation and then we have treatment. I think you're finding this interesting. Okay. Let's start with the history and examination now. So goals on the history and examinations just to rule out the cause, the other causes and the underlying causes. Okay. So first, you have to ask the patient exactly that who is giving the history, etc. Who has witnessed this seizure? What type of seizure was there? On the basis of the relevant history, you can identify the types. Just what we discussed. We also have to ask for the risk factor, like does the patient has fever? Is there any family history? Or if there is any unrecognized auras. Were you feeling strain? Were you having certain different type of smell? Were you having some sensations, photophobia, phonophobia, etc.? These are the auras you have got. Because if it's an aura, then you know it has to be focal seizures or maybe even MTLE, etc. Complex type of seizures. Then epileptogenic factors like head trauma, stroke, tumor, CNS infection has to be ruled out. Precipitating factors should be asked. Was there a sleep deprivation? Then you know there are microepilepsy. Systemic illnesses, electrolyte, metabolic derangements, alcohol or drug use can be asked. Finally, coming to the physical examination. Physical examination will give you clues with the help of neurocutaneous signs for tuberous sclerosis, neurofibromatosis, even organomegaly will give you metabolic disease, even brain injury can be identified with the help of muscle weakness, etc. Now you can get the idea of stroke and all. Okay. Then mental status, visual fields, motor and sensory functions are the other neurological examination that will give you clues for the diagnosis. Yes. So finally coming to the laboratory studies. So routine investigations we will do. So CBC will be important to do in these patients just to get to know about the anemia, etc. All those conditions. Just to know about the TLC. Okay, very important TLC just to rule out CNS infections. Okay, even platelets, etc. To rule out bleeding in the brain, etc. All those things. Okay, so that will be important. Then electrolytes. Okay, as you know, various electrolytes like hypernatremia, etc. can cause metabolic encephalopathy, even EVG. Okay, even calcium, magnesium, sodium. Okay, sugars, very, very important. Okay, so this all will give you even RFT, right? Uremia, etc. All will give you clue for the diagnosis. Along with that, toxic screen should be done if person is taking certain either drugs or if there is copper poisoning, etc., or any other substances abuses there. Okay, then lumbar puncture can be done if you are suspecting meningitis in these patients. Autoantibody testing, mostly if you are suspecting autoimmune encephalopathy in these patients. Okay, so finally coming to the EEG, what features you will get in the EEG? So EEG basics, I think it will be little in depth over here, but I'll try to cover most important things. So whenever you are awake, you will have 8 to 13 hertz of alpha rhythm. Okay, that is mostly posteriorly and intermixed with the beta activity. Okay, so alpha with beta is normal thing when you are awake. When you are sleeping, you mostly have theta waves. Okay, theta waves about 4 to 7 hertz when you are sleeping. When you are awake, 8 to 13. Okay, that's your alpha. Okay, so these are about the EEG. Now let's see. When you have the seizures, you will have abnormal repetitive rhythmic activity, and that will confirm the seizure. So this is a very important part. Okay, and when you have interictal EEG, depending on spikes and sharp waves, you can identify the interictal EEG also. That means EEG can be done at any point. When the person is having seizure, that's called as ictal EEG. There you will get the abnormal repetitive rhythmic activity. But if somebody is having, somebody has the history of seizures now, or if there is some underlying property, underlying activity is going on, then you can get this epileptiform discharge like spikes, sharp waves can be seen. Okay. Yes. So with the help of this, now, if these are not helping, if this ECG, simple ECGs are also not helping, We can have some other, terminal procedures like activating procedures. For example, hyperventilating, photic stimulation, sleep deprivation. So this will trigger the seizure in the person, and we will now get the ictal EEG. Okay, ictal EEG we can do to confirm the diagnosis. Then we can also do video EEG telemetry, recording the patient's events, prognosis with the EEG usually. So if there is a persistent activity in the background, there is a worse outcome because that means patient is in the status of it. Or advanced techniques can be used in the form of MEG, that is magnetoencephalography, or magnetic source imaging, MSI. Okay, so these are the new things that is given in the Harrison. Now, coming to the differential diagnosis of the seizure, which we have to rule out on the history. So, out of this, most important is syncope and the psychological disorder or functional seizure. So, in functional seizure, usually patient stays like that for a long time, and most of the time, patient will complain that I had a seizure. In case of organic seizure or the regular seizure, relatives or somebody must have seen the episode and then complains about the seizure. We will see the difference, don't worry about that. The metabolic disturbances should be also considered before considering epilepsy. Psychoactive drugs, migraine, transient ischemic attacks, sleep disorders, movement disorders, and in case of children, breath holding spells in case of congenital heart disease, cyanotic congenital heart specifically, then migraines, BPPV, apnea, night terrors, and sleepwalking. So these are all things should be considered when we talk about the seizures. Now, let's see the difference between seizure, syncope, and the psychogenic seizures. So as I said, seizures are usually unprovoked. Syncope can be provoked. For example, micturition syncope, when you pass the urine, or defecation syncope, or just orthostatic hypotension. Okay, that's also one of the cardiac syncope. So, or any arrhythmia. So all these are syncope. So they have the underlying cause. Okay, if they don't have any cause, then we have to tell it as a seizure. And there is psychogenic seizure. You will have the history of psychological distress to the person. Okay. Then aura, it's common in case of seizure, not in case of syncope, and not in case of psychogenic seizure. Motor activity. So you just have to ask the history that before seizure or before this event, did you feel something off? Did you notice something different or strange? Then they mostly psychological says, no, doctor, I don't know anything. Suddenly the seizure came. That's very classical difference between those two. Okay. Then motor activity, tonic-clonic activity will be there, and the rhythmic activity will be there. But in case of psychogenic, the bizarre activity will be there. Okay. No rhythmic activity will be there. Whereas in case of syncope, sudden episodes of unconsciousness will occur. Then duration of moments, here is short, here is very, very short, and it's a prolonged. As I said, a person will be in an epilepsy for like 30 minutes or something like that. And he will get better even without treatment when he feels fatigued, relaxed. Maybe if you're trying to, have this type of patients, give them some placebo medicines, they'll feel better. Post-event state. So here the disorientation, sleepiness, muscle soreness is classic in case of seizure. Okay, here, whereas in both of these cases, you will have no confusion. Incontinence is occurring in the seizure only. Loss of consciousness always occurs in case of seizure. For a brief period of time will occur in the syncope. And here a person can act of loss of consciousness. Okay, recovery gradual with confusion. Here quick and complete recovery can be there. Eye features, eyes open or upward gaze can be seen. Pelvic thrusting is rare. Okay, here it is common pelvic thrusting. That means applying the pressure with the pelvic girdle. EEG findings, where you will definitely get the epileptiform discharges, but rest of the time you will not get. So these are very, very important points that you should consider when you have the patients of epilepsy. All right. Now let's start with the treatment. I know you have been waiting for this from long time. All right. So let's start with the treatment. So we'll discuss this MCQ once we cover the treatment now. All right. So let's start with the treatment. First of all, we have the multimodal approach. First, we should focus on treating the underlying causes, treat the underlying cause, avoiding the trigger. Then you can give medications. Then after that, and surgery. And finally, psychological, etc. issues which occurs after the seizure. For example, psychosis, depression, which are very common. Okay. Along with that, always treat the underlying conditions like metabolic disturbances, treat the hyponatremia, hypokalemia, hypocalcemia, hypomagnesemia, whatever the issue is. Drug-induced seizures, suppose if it is, for example, theophylline, cocaine, then treat the cause, stop those drugs. Okay. Then if there is a structural sinus lesion, for example, Either abscess is there or tumor is there. Okay, tumor, abscess, anything is there. Or if patient is having anti-seizure medication, okay, maintained for at least 1 year post-treatment. Okay, then withdrawal of medication considered if seizure free for an extended period, and surgery may be necessary for the refractory cases in case of structural CNS lesions. Okay, so initially you can give anti-seizure medication and then you can see how the patient responds. Okay, that's about the structural CNS lesions. Right now, how to avoid precipitating factors. So sleep deprivation should be asked to advise. Alcohol should be asked to stop. Stress, you obviously can't say to don't take stress because we all of us are in the stress, but you can ask for the methods like meditation, counseling, etc. Okay. Then reflex epilepsy. Sometimes after specific flashing stimulation, that's why sometimes you might see in the movie that the movie contains, epilepsy sensitive lights. Okay, so that can lead to the epilepsy. Video games, music, voices. So in this case, I ask the patient to avoid those things. Okay, so coming to the pharmacology now, anti-seizure drug therapy. So which of the following is the risk factor for the recurrent seizure that warrants initiating anti-seizure drug therapy? So first is absence of brain image abnormalities, leads with the epileptic form abnormalities, a single seizure with a nocturnal occurrence, and no history of prior brain injury. So obviously, as I said, if there is an unprovoked seizure, most of the times you go for the start of the treatment. Okay, and then which anti-seizure drug is contraindicated in patient predisposed to leukopenia or hepatotoxicity? All right, we all know this. Let's see the treatment now. So goal of the therapy is prevent seizures without the side effects using simple dosing strategy. All right. So treatment or drug selection is on the basis of seizure type. As you know, focal seizure has different treatment, or generalized seizure has a different. Okay. Then drug-drug interaction should be considered. Medical comorbidities, cost, dosing, convenience, all should be considered. So the first line is most of the times is phenytoin valproate, but now considering the type of the epilepsy, we have the types. Okay, and role of genetic testing is also important for the to check the drug-drug interaction. So right. So now let's see this very important point that when to start anti-seizure drug therapy. The first point is if somebody is having a recurrent seizure of unknown etiology or irreversible cause. That's the first point. Then I'm going to start anti-epileptic treatment. Okay, that recurrent seizure is there, but no underlying cause is there. No etiology is known. And second point, single seizure with identifiable epileptogenic lesions. For example, if somebody is having CNS tumor, then definitely I will start treatment because he has the underlying cause. That means single seizure or one seizure with a provoked cause. Okay, one provoked seizure, even one provoked seizure. Okay, that's your indication to start the treatment. Okay, even one provoked seizure, right? Then risk factors for recurrence, prior brain insult. Here recurrence can be seen, e.g. with epileptiform abnormalities, significant brain imaging abnormalities, and nocturnal seizures. So whenever you have nighttime seizure, etc., all these things can give rise to risk of recurrence. And then you have to consider to start treatment. Now, controversies, single unprovoked seizures have variable recurrence risk, 33 to 71%. So obviously it depends on these risk factors. Okay, and employment and driving consideration may influence decisions. Right. So based on this now, focal, generalized, typical, and atypical absence. So we have different types of first line treatment choices. So let's see over here. So valproate and lamotrigine are the first line in generalized tonic-clonic seizures. So this is a very important point, guys. Please note, phenytoin is not included in here. Okay, phenytoin is not here. Okay, even your levetiracetam is not there. Okay, even levetiracetam is not there. These are first line, only lamotrigine and valproate. So suppose in exam, they ask, which of the following is the first line drug recommended for the generalized seizure as per Harrison? Or in general, they ask. Then you have to tell, and they give option, lamotrigine, phenytoin, carbamazepine, levetiracetam. So you can get confused. So please remember only LV. Okay, LVF. Okay, you can just remember left ventricular failure, LVF. That's for the first line. Now talking about the focal, you have multiple, but as you guys already know about the carbamazepine, toxcarbamazepine, you can just remember lamotrigine also with this because that also causes Steven Johnson syndrome. So these three are in blanket. Then carbamazepine also come with this. Then phenytoin is one more thing and levetiracetam. Okay, so you can just remember CPL. Okay, CPL. Okay, Caribbean Premier League. Please remember this. Okay, or you can just remember CFL, something like that. Okay, CFL also. That carbon phenytoin and a phenytoin and levetiracetam for the focal, for the first line. Then for typical absence, you guys already know valproate, ethosuximide are there. Even lamotrigine can be used as first line. And for atypical absence, valproate is used. Okay, valproate, lamotrigine, and topiramate. Remember, ethosuximide is not used over here. Okay, ethosuximide has no role over it. Okay, so valproate is used in both of them. Okay, so please remember these are the choice of anti-epileptics first line. Then depending on that second line can be added clonazepam, felbamate, clobazepam, dofenamide. Okay, so this list goes and on. All right, but here remember over the first line treatment at least. Okay, so then initiation and monitoring of therapy, how it should be done. So first we should start with a slow dose, lowest dose. Start slowly with lowest dose, increase gradually after achieving a steady state. Because drug level has to be achieved in these cases. And then monitor serum drug levels for dosing guidances. Okay, then measure free drug concentration for the patients just to check the drug effect, and gradually switching of the drugs should be. Okay, then when do we discontinue therapy? Remember this very, very important point. Once epilepsy, not always epilepsy. So seizure free, if patient is there for 1 to 5 years, then you can stop. Okay, single seizure type, generalized or more than focal prognosis. Okay, so prognosis, if we talk about, and if patient has a single seizure type, mostly generalized has a good prognosis. Okay, normal neurological and EEG findings, no family history of the epilepsy. Okay, how do we taper it? So gradually we have to taper over a period of 2 to 3 months. Suddenly you should not stop the process. Okay, and remember, most of the epilepsy can reoccur within the first 3 months. Okay, therefore go very slow while stopping the treatment. Up to 20% of the patient may not regain full control, and you can have to again start the treatment for this patient. All right. Finally, coming to the treatment of refractory epilepsy, in these cases, if patient is having mesial temporal epilepsy or anything like this, you might have to operate. But before that, try the combination therapy. So combine drug with different mechanisms. This is very important point. So lamotrigine plus valproate is a different mechanism. Okay. So commonly used iodines are zonisamide, brivaracetam, topiramate, lacosamide. Okay, lacosamide is very familiar. Tiagabine. Okay, so lacosamide, tiagabine can be commonly used. Even brivaracetam can be used. But remember, it has to be used with a valproate. Okay, also you can add lamotrigine. If you use valproate, levetiracetam, they act in the same way. Okay. Special cases, in case of myoclonic seizures, levetiracetam can be used. It has good effects in this. Zonisamide, clonazepam will be more beneficial. In case of absence seizures, valproate and ethosuximide can be done. All right. So this is a master chart of all the epileptic drugs. I will just highlight the few important things over here. All right. So as we just discussed, brivaracetam for the focal onset, and carbamazepine for the focal again. Okay. Ethosuximide for the absence seizures. It can have GI irritation, ataxia. Carbamazepine can have aplastic anemia, GI irritation, hepatotoxicity. Okay, very, very important. Okay, aplastic anemia is the feature of this. So that was the MCQ they asked for. Okay, then lacosamide. Okay, it's also used for the sorry, for this. Okay, there's some problem with the ink. Anyways, okay, yeah. So lacosamide is there for focal seizures. It can increase the PR prolongation and also cause GI irritation. Then lamotrigine is there. Lamotrigine can also be used for focal, tonic-clonic, myoclonic, and even Lennox-Gastaut syndrome. L for L, you can remember. And it also causes Stevens-Johnson syndrome, as I've been saying, for just like carbamazepine and Knox-Townes. Okay. Then finally, this commonly used drugs, your levetiracetam can cause sedation, very important, mood changes, leukopenia. So never advise patient to drive after taking these tablets. Then oxcarbamazepine is also causes fatigue, ataxia, diplopia, gives in focal seizure. Parampenel, 5-compa, very, very important, given in refractory seizures. Okay, acts on the glutamates. So it is focal tonic-clonic seizures and it causes aggression. This is a very, very important point for your MCQ exams. What drug causes aggression in epilepsy? So that's a parampenel or 5-compa. Okay, 5-compa. Then phenobarbital, That also causes sedation, skin rashes. So dosage and all it's given over. Okay, I'm not covering doses because it will again take a lot of time for us. You can revise doses on nothing to worry about. Phenytoin. So for phenytoin, we know the side effects already. Gingival hyperplasia, ataxia, okay, paradoxicity, confusion, etc. can be seen. Then rufinamide can also be used in Lennox-Gastaut, just like lamotrigine. Okay, tiagabine is there and topiramate. Topiramate causes weight loss, so has been used in case of patients of epilepsy with weight loss, weight gain or obesity. It helps in obesity as well. Okay, so cognitive slowing, renal stones, glaucoma. Also, topiramate is used for the migraine prophylaxis. Okay, so as we just discussed, these are some of the important points we should know for your exam and for practice as well. So carbamazepine, carbamazepine, and phenytoin, these are enzyme inducers. Okay, so whenever you are giving with any other antibiotic drugs, they reduce the drug levels. So be very, very vigilant in this case. Okay, they are the enzyme inducers. Okay, then felbamate causes aplastic anemia risk. Even carbamazepine causes this. Gabapentin, no major drug interactions. It's good drug. Lamotrigine causes Stevens-Johnson syndrome. Okay, and lacosamide prolongs PRN. Okay. Now these are also some one-liner which are added. Which anti-epileptic drug is associated with gingival hyperplasia? That's phenytoin. Which anti-epileptic drug has the longest half-life of the enzyme inducing? So phenobarbital, 90 hours. It's quite long, right? Then which anti-epileptic drug is associated with the aggravation and the panic attacks? That's perampanel. I've already told. Then which anti-epileptic drug is associated with psychosis as well? So tiagabine. Okay, that's also one liner you have to remember. Which anti-epileptic drug is contraindicated in patients with kidney stones? So that's topiramate. Because it causes kidney stones. Okay, I will discuss over it. Okay, so it can cause renal stones. The small point from this table have been asked for a MCQ, like majority of it. So please go through this once. Okay, so coming to the surgical treatment now. Following surgical procedure commonly performed in temporal lobe epilepsy is amylohypopectomy because it causes hippocampal sclerosis, right? Then, which neurostimulation device involves closed loop stimulation by detecting seizure onset and delivering the target electrical impulses? That's your responsive neurostimulation. Okay, so VNS is mostly used for the migraine, etc. Responsive neurostimulation is used for this type of epilepsy. Okay. Yeah. So this is the surgery and indications. What are the different types of surgery we have? The temporal lobectomy, amygdalohypopectomy, lagenectomy can be done. Okay. Sometimes hemispherectomy, corpus callexectomy. Okay. For generalized seizure, corpus callexectomy may help. Okay. Subpial transection can be done. Okay. Based on different new procedures are also there. The surgical evaluation with the help of video age, etc. can be done. Emerging technique like stereotactic laser thermal ablation is there. Neurostimulation procedures are there like this. Okay, so it has good success rate, can also have some complication as well. All right, so that's all about the epilepsy, guys. I hope you like the session. We are comprehensively covered in 1 hour and 42 minutes to be approximate. And now we have status epilepticus. I will just talk about few important things in the status epilepticus, and then we will end this session. Okay, so as we know, status epilepticus means the epilepsy keeps on continuing. We mostly have two subtypes. First is generalized status epilepticus, which are convulsive. Okay, generalized convulsive status epilepticus and non-convulsive status epilepticus, which I said. This is mostly seen in the ICU patients. Suppose patient is intubated and we are not able to wean off the patient off ventilator, and then you can suspect this non-convulsive status epilepticus. So it has happened to me. We had a patient in the ICU. We were not able to revive him or wean off ventilator from him. We did MRI a couple of times, but we were not able to get any diagnosis. Then we gave the neurology referral, and they said that it can be MCSC. So probably we should do EEG first. We did the EEG and we got the epilepsy. We started him on antiepileptic because he was already on antiepileptic. Then we had to increase the dose of antiepileptic, and he got better. Okay, so it happens. Remember, both of the things you should know. Now, as we have watched this video, right? So practical definition is status epilepticus is typically considered for acute treatment when seizures are beyond 5 minutes. This is very, very important. But if the prolonged seizures more than 15 to 30 minutes keeps on going, then metabolic derangements like CNS injury, metabolic derangements in the form of rhabdomyolysis because of muscle breakdown can occur. Now, what are the common causes? Most important and most frequent causes: anticonvulsant withdrawal without prescription of the doctor or non-compliance to the doctor's prescription. Okay, like metabolic disturbances can also be the causes of drug toxicity, CNS infection, tumors, and refractive epilepsy. These are some other causes of the status epilepticus. Okay, so patient can have tonic-clonic movements. Sometimes subtle signs can also be there, like mild clonic movements in the finger, rapid eye movements can be there. Okay, sometimes tachycardia, hypertension, pupil dilation can also be there. So we have to do the EEG, and after EEG we can confirm the diagnosis. Now, first of all, we'll try to stabilize the patient, airway, breathing, circulation. We'll do brief neurological examination, send some samples, and in both the cases we will do the same way and start for the treatment as per this protocol that's given in the Harrison. So first is lorazepam. Now, why this lorazepam is important? Because it will make the patient or CNS depression in this case, will suppress all the activity. And what is the dose? 0.1 mg per kg. Now here the dose becomes important for your theory exams as well. Okay, so dose of lorazepam is important, 0.1 mg per kg. Similarly, in case of phenytoin, so after this lorazepam dose, we have to give anti-seizure drugs. So first drug of choice is phenytoin and valproate. So for phenytoin, I'll just write phenytoin and valproate like this. Okay, sorry, valproate. For phenytoin, we give 15 to 20 mg per kg, and for valproate, we have 20 to 30 mg per kg. Very important, very important. These two things. And levetiracetam, if we give levetiracetam, we give 20 to 30 mg per kg. So I'll just give you an idea that most of the drugs are in the 15 to 30 mg per kg. Okay, most of the drugs except your propofol, and pentobarbital. Okay, it's 5 mg per kg, and propofol is 2 to 10 mg per kg. Rest of them are 15 to 30 mg per kg. Okay, so if now after giving benzodiazepine and the anti-seizure drug, the patient is having, so suppose you are able to make the diagnosis, these are focal complex seizure or myoclonic seizure or absent seizure, then you have to further give medicines. Okay, like valproate, levetiracetam, okay, lacosamide, right? So all these drugs can be tried. Okay, pregabalin, etc. can be given. And here, if patient is not recovering now, still after giving all those medicines, then we have to give midazolam and the propofol or propofol. Okay, and or propofol. So what is the dose again? For just was like for lorazepam 0.2 mg per kg, and here for propofol the dose is 2 mg per kg. Okay, so 2 to 10 mg per kg per hour infusion can also be given. And even if that doesn't help now, we give pentobarbital. So for pentobarbital or phenobarbital, the dose is 5 mg per kg. Okay, PHP, phenobarbital. Okay, and eventually, if even that doesn't help, then we can give isoflurane, desflurane, ketamine. These are some other anesthetics can be given. Or you can also give lidocaine, verapamil, magnesium, okay, ketogenic diet. So that's for the long term, but you can give anesthetic, and you can try some long-term surgery approaches also if patients have a refractory approach. Okay, so that's all about the epilepsy. And after epilepsy also there are psychiatric disorders like depression can occur in 20%, anxiety, post-ictal psychosis also are the risk factors that we have to worry about. And some special scenarios also there. For example, catamenial epilepsy, where during menstrual cycle, you can have the epilepsy. That's catamenial epilepsy. During pregnancy also, seizure changes, unchanged in 50%, increase in 30%, and decrease in 20%. That can be seen. Okay, so that can lead to the higher fetal abnormalities. So management has to be done mostly monotherapy in these cases. And you have to give folate to avoid the folate and vitamin K to avoid the complications. Also, contraceptives sometimes would be helpful if patient is already on the anti-seizure drugs, because there are teratogenic effects also. And breastfeeding, in case of breastfeeding, 5% of the valproate and 300% of levetiracetam can pass to baby. So make sure you shift to the safe drug depending on how much drug that is going into the menses. All right, so you have to encourage the breastfeeding. Breastfeeding is not contraindicated, but remember that drug you are giving and the less amount of secretion in the breastfeeding. All right, so that's all. Thank you so much for this session. I hope you like the comprehensive discussion on the epilepsy. Okay, we saw almost everything that is given in the Harrison in a comprehensive way, and I hope if you watch this video, you'll be able to uh, crack any question, either it is theory exam as well as MCQ exam when we talk about the epilepsy. All right. So that's all for my time. This is Dr. Vishal Gabale. Thank you so much again for Dr. Kishan sir for giving me opportunity to be here. And you can follow my YouTube channel, Dr. Vishal Gabale, where I am posting such videos. Also, I have new channel that's Adrenaline Medal on my Instagram and Health with VG. Okay, on Instagram. So Adrenaline is in both Instagram as well as YT. Okay, and Health with VG is also the same Dr. Vishal Gabale on IG and YT. Okay, along with that, if you have any doubts, here is my number 7588. I'll just write it in white hospital 7588 54545. Okay, he's my manager. He will help you to guide this. Okay, so thank you so much, guys. I hope you like. Also, entire Harrison lectures we have kept. So if you also want those, you can message on this number. So thank you. I wish you all the best. Let's meet in the next lecture. Okay, I think we can. Yes.
Recording stopped.
Yes.